bit at what you were saying about your interest with research, but what do we think is the most exciting innovation? Either something that has happened in the last couple years or something that's in the pipeline that is starting to sort of percolate up towards being particularly interesting. What do we think is one of the most interesting, important, intriguing innovations in GYN cancer care in 2020?
Yeah, so I think it's a little bit different depending on which disease you're talking about. Certainly the therapies have just been advancing substantially. I mean, I used to put up a slide of, what had been FDA approved over the last 20 or so years. And it used to be like every few years we had something. And it was just not that exciting. We weren't really making that much progress. But in the last few years, there's just been one thing after another. And it's actually hard to keep up with all the changes that are happening, and very, very exciting. And more than that, there are a lot of new clinical trials. There's been a lot of investment, both through the government and through pharmaceutical companies in developing drugs for patients with GYN cancers. So it's exciting. So I think it depends on which disease you're talking about. I think if you're talking about ovarian cancer, then the newest, biggest and brightest thing would be PARP inhibitors. And we've known about them for a while, but they just keep making a splash over and over again. If you're talking about endometrial cancer, then you're talking about immunotherapy. And there similarly, we thought that it was only going to be applicable for a small segment of the population. And now we have it available in different situations. In cervical cancer, there's some very exciting clinical trials that are going on with various different approaches using immunotherapy, and we're just really hoping to see some true advances in that area. And then just generally thinking more about this idea that we've been talking about for quite some time, but haven't capitalized on yet, which is the idea of personalized medicine. Now we are actually getting closer to that, where we can really truly try to identify specific targets for specific cancers that are going to be beneficial. And we're not truly there yet, but we've definitely made great strides. And it's an exciting time for us to have new options for patients. So that's what I'm most excited about.
I think somebody else started to answer also. Did somebody else want to answer?
Yeah, I think I kind of started to answer because I think exactly what Dr. Garrett said, which is like, even 5 years ago, you didn't have these genetic tests that you could do and then have all of these other, all these new targeted therapies. I think the most exciting thing is that it's not just that we can look under the microscope and say, oh, this is the type of cancer, therefore these are the treatments we recommend. We can actually look at the genetics and the epigenetics of the cancer and say, well, these are treatments that we expect to work because of what we see here. And then I also think that immunotherapy is just very exciting. Initially for just specific subtypes of endometrial cancer, but now with the addition of lenvatinib, we can give it, anyone with endometrial cancer can be eligible for immunotherapy, and the responses we see are so, when it works incredibly well. And I think that's probably one of the biggest changes that we've seen.
I was just going to add to more sort of on the front end. I think we know we're starting to learn more and more what we can do in terms of primary prevention of gynecologic cancer. Whether you're talking about the HPV vaccine, which can prevent over 70% of cervical cancers, or you're talking about, really capitalizing on knowing family history and doing genetic testing to talk about, surveillance and or risk reducing surgery for gynecologic cancers. And then sort of in the population at large, sort of this idea of opportunistic salpingectomy, the idea being that maybe all along, much of what we thought was ovarian cancer actually starts in the fallopian tubes, and that when women are finished having children and are undergoing abdominal pelvic surgery for whatever reason, removing the fallopian tubes is an effort or as a primary prevention strategy for ovarian cancer is, to me, the idea of that and what we've already seen epidemiologically when we look at populations that engage in that type of intervention is incredible.
That's a good addition. To go to the subject a little bit of clinical trials, one of the participants on the line actually asked, how do you decide, or who decides whether you're going to go a standard treatment route or a clinical trial route? Dr. Gaillard mentioned probably, you know, when patients come into her office, there's definitely a lot of conversation about clinical trials. But how does everybody decide clinical trial, standard of care? What are the considerations, and how do you advise and counsel patients?
Yeah, so I'll field that one first. So the way I think about it is reasonable to consider a clinical trial in any situation where standard of care is not optimal. And what I mean by that is, if standard of care is going to yield cure of the cancer, then don't mess with that, right? Like, we definitely don't want to mess with something that works and we know is going to work well. So if that's the case, great, go with standard of care. And many times our standard of care are very good, but there are high-risk situations where it falls short of that. And so those are situations where if there's the right clinical trial, you might consider it. So this is where the nuances come in, and trying to choose a clinical trial. You wouldn't, if you're someone who's newly diagnosed, you wouldn't choose just any clinical trial. You would want one that is at least going to give you the standard of care and perhaps add something onto it that may yield additional benefit, right? So that would be reasonable. And then, but there are other situations where perhaps patients have already had the standard of care options, and yet there may be other available therapies, but their benefit is, you know, less than we would like. And so that might be a situation where you consider a clinical trial. And so my main message is, it's always worth asking the question. It is definitely the case where you want to do it under the guidance of your physician, who can help tell you whether what the standard of care is the best thing out there, or even if there are clinical trials in that particular area, because sometimes there aren't necessarily always clinical trials for every particular clinical scenario. But asking those questions, I think, is good, and being in a mindset of trying to find out what else is going on, I think is helpful to have early on, rather than leaving it to, you know, down the road. And the one thing I try to remind everyone is that the advances that we have made, so what we were just talking about, these new drugs that are now available and are FDA approved, and the many drugs that have become FDA approved in the last few years, only got there because people were brave enough to enroll on clinical trials. And, you know, we always hope that patients are going to benefit from trials. It is not always the case, but we certainly always learn from the trials that we do, and we make incremental steps forward, and that's how we advance the field.
Along those lines, a lot of patients go to Dr. Google when they're first diagnosed. And so when patients come in and say, I read this on Dr. Google, or I found this on Dr. Google, how do you respond, and what do you advise? What are your top resources? If a patient comes to you and says, I love Dr. Google, but what do you like for resources? Where should I look? What do you recommend?
Are you addressing that to me directly?
No, anybody on the call, anybody can answer. All of us get, this is such a common question, right? The internet has so much information on it. There's no shortage of thoughts and opinions on the internet and blogs and resources. And so I think all of us have our favorite resources probably, that when patients say, where should I look? Where should I go? We sort of say, well, these are my favorite places. Maybe some people say, don't do it. Stay off Google. Everybody has their own answer. So, and there's no right answer, right? So what does everybody say about what does everybody say when people ask about Dr. Google?
I often tell people not to Google, or I will tell them to Google if I know that there's good stuff out there. But I think the Mayo Clinic, often when you Google anything, often one of the first things that shows up is a Mayo Clinic link. And often they have, I don't know, their websites are really well written at a patient level. And it's usually pretty basic. And then, you should ask your doctor about XYZ. And then, I mean, Johns Hopkins, of course, has their own as well that are quite good. But I've noticed for diagnoses, I do like the patient communication that you get through the Mayo Clinic website.
And one of the ones that I really like is the Foundation for Women's Cancers, because they do a really nice job of breaking it down, and it is very specific to the questions that patients with these cancers have. They also have lots of great information on clinical trials, and so when someone has gone there, it makes my job easy, because they often are coming in already having some information to start with.
I like the CDC, actually, if you can believe it. The CDC has a thing called their Inside Knowledge campaign. There's a link in it. It's basically a link that sort of, is informative and raises awareness about the 5 main gynecologic cancers. And they have like 1 million other links. And I think that it is very user-friendly.
And also, I would say the American Cancer Society has very patient-friendly. If you just don't know where else to start, it's a good place to kind of get used to seeing these words and the definitions, and then enough to then move on to some of these other sites that are going to be very specific. I also like the Foundation for Women's Cancer sites as well.
I think patients also like to watch YouTube videos of surgeries, like of laparoscopic and robotic surgery. And I actually think there's some good videos out there, and the AGL, has good surgical videos that folks can watch. So.
Yeah, if I'm doing sentinel lymph nodes on someone for endometrial cancer, I tell them to Google it because it's so cool.
I Google it in the office and show it to them. So even I do the Dr. Google sometimes, I will admit.
I think we all do. It's a good way to start your PubMed search when you're down the rabbit hole on a topic that you want to get more information about. Any other resources people think are helpful or enjoyable for patients? You mentioned videos, Dr. Stone. SurvivorNet is starting a series of videos on different topics, and some related to GYN cancers. So those are quite good. And Sharon, you had some thoughts and suggestions.
We give a lot of the links from the National Cancer Institute to patients. They have a lot of pamphlets on the different cancers, chemotherapy, nutrition, radiation, each of the individual GYN malignancies, and they actually even have some nice publications for dealing with children of cancer survivors and spouses and that sort of thing. So I give those links to patients all the time, and they're available online now. We used to have to order them and, pick up these big boxes full of books, but now we can just give patients links. So that makes it nice too.
Very cool. We're getting close to the end, and so I sort of want to end with like a little bit of a semi-serious question, or more. All of these questions have been serious, but a little more challenging question I think that all of us face, which is when patients first get a diagnosis of their primary cancer, or they get a diagnosis of recurrence, or the chemo's not working. The daytime hours are often spent like very focused on, what do I need to do? How do I take care of my physical health? How do I get better? but maybe not so many daytime hours, or for some people many, but oftentimes our daytime hours are very practical. And our nighttime hours, when we're alone or it's dark, are more introspective and can often be very scary. And so I think a lot of patients come into the office and sort of expect us to take care of the physical piece, but then also help them sort out how to address that sense of overwhelmedness that comes with this process, and that sense of scariness that comes with that process. And so what words of wisdom do people share with patients when they say, I got the daytime stuff, but what do I do about the nighttime stuff? What do I do with my worries?
One thing that I have found helpful for some patients is to journal it, write those things down, and bring it with them to clinic, and we can talk about it. Or one of the more powerful resources I think we have is the Sisterhood of Caring, where we have patients who volunteer to talk to other patients. And I think you really can't get any better than that.
Yeah, I think that peer mentorship for many of my patients, especially, you know, there's certain diagnoses, let's say advanced ovarian cancer, where, you know, there's surgery and chemo involved, and you're looking at 5 or 6 months of treatment. I have, you know, patients who have found other patients who are 2 years plus kind of down the line, and it's really helpful to see someone who's finished and kind of gotten past that finish line of the original, you know, the first preliminary treatment. So I think kind of seeing that there's a light at the end of the tunnel by seeing someone who's gone through it can be really helpful. And Paula Silverman is our survivorship coordinator, and she's wonderful. So whenever patients have any questions like this, I always refer them to her, because whatever you need, she can figure it out, and she has a resource for it. It's incredible, and we are so lucky to have her. She has, I think, changed the lives of so many patients. So I really appreciate that we have her as a resource.
Yeah, and I also want to point out, you know, and highlight some of the work that, you know, Anna is particularly spearheading with our Health Leads program. I think for many patients, right, I mean, this just a cancer diagnosis, it's not just that, it's everything, right? It's expensive. It's how do I pay my bills? How do I eat healthy? How do I even eat? You know, how do I take care of my family, small children, or, you know, aging mother who lives with you? And you know, so we have a lot of resources, you know, more than we ever used to help our patients with this. And you know, one of the main mechanisms for that is, you know, through our Health Leads sort of resource identification program. And you know, they're incredible. I mean, I just personally can speak on behalf of some of my patients, the messages that I get from them about patients who were able to buy Thanksgiving dinner, or, you know, have childcare for an hour or two just to be able to have some time to think, or just things like that. And then the other thing too is, I think sleep is incredibly important. I think we all know, you know, and the fatigue that patients who are getting cancer treatment feel is just, I don't think any of us on this call can even understand that. I know it must be so profound. And so, but I also think that things change, right? And your circadian rhythm changes, you know, at different times in your life and when you're going through different things. And so the idea sometimes, I think that, you know, that how things were for you might be how they are, you know, during different points in the, you know, cancer treatment journey, isn't necessarily the case. And I tell patients, you know, like, I feel like some of my patients lay awake in bed and they're like, I just can't sleep. And I'm like, okay, fine. Like, don't sleep then. Like, get up and do something, you know, write a letter to somebody, or, you know, watch TV or cook, and then, you know, maybe you sleep during the day. I mean, Winston Churchill was like classic for that. There's some brilliant people who have, like, you know, different sleep schedules. You don't have to be like fit into that box of like sleeping from, you know, 10 p.m. to 5 a.m. or whatever. Like, it's okay to like go your own way.
Yeah, and I would say, so just to reiterate what Dr. Stone was talking about, you know, I think a lot of times when you hear the word cancer, kind of everything else falls to the wayside, and you kind of ignore things in order to treat that cancer. And so, you know, initially there's going to be a lot of things that need to happen to get your care taken care of. But then as kind of the dust settles, you want to make sure that you are able to get those rides. And if you can't get a ride to the hospital, we need to know, because that's actually part of your cancer care, is making sure you can get to us, not just giving you the chemo when you get here. You know, if you are having trouble, like Dr. Stone said, with childcare, or, you know, you lost your job and you think you're going to lose your insurance. So these are things we need to know ahead of time, because we don't just want to prescribe you chemo and do your surgery. We want to make sure that we take care of you outside of the hospital, as well as, you know, take care of the cancer. And then one other thing that I think is important is that when you do get through the treatment, whatever that is, it may just be a surgery, it may be a surgery plus chemo plus radiation. When again, I guess the dust settles, you may start to feel things like you want your sex life back and you feel guilty because you survived cancer. So should you want that back? And that's okay. It's okay to want a normal life back, and it's okay to want a normal life while you're being treated. And these are things we want to hear about, because we do have resources and we can help.
So what I would say is this is such an important question, because it gives us an opportunity to engage in that exchange of information. So what I always try to explore with patients is, yes, cancer is a huge event in their life, but patients have lived through sometimes so many huge events. And what are other things that they have done when these other huge events have happened that have helped them? Whether it's their spiritual community, whether it's meditation, whether it's exercise, what are those things that you're already doing that you know work for you or have worked for you in the past? And let's revisit some of those things. Also, I try to, you know, talk about when we're facing such a huge challenge, let's break it down into smaller pieces. What's the next thing that needs to be done? What's our plan? You know, if it's just, you know, making an appointment with a social worker, you know, that's another piece to bring in, that, you know, a lot of times patients haven't ever gone to therapy and there's a stigma around that. So, you know, do we need to do that? Or let's just make the appointment for the scan. Let's go there. And then once we get the scan back, let's focus on the next step then. So those are usually the points that I touch on.
There's a lull and it doesn't look like anybody else has unmuted. And we're actually very close to the hour mark. So thank you all very much. I am going to end with a little bit of, hopefully my screen sharing properly, and just a few little tidbits, and then a little bit of closing celebration. So a few little tidbits on the resource front. Everybody mentioned there are a lot of resources here at Johns Hopkins, and our website has a lot of the resources listed on them. Certainly all of our survivorship programming, resources for patients, which has now been included as a Word file that you can download, and that's a living, breathing document, so it will continually get updated. So you can certainly access our website as a starting point for resources if you need resources. Everybody mentioned reaching out to our nurses, to our physicians, to our PAs, to even our residents and our fellows know how to access these resources. To Paula, anybody on your treatment team is going to be able to help you if you have a need. So certainly speaking up, but if you need if you want the privacy of your own home to start looking for resources, we have some on our website. And it includes information about all of our programming. So we do an annual race to raise awareness and to raise money for our research and our fellowship programs and our survivorship programs. We have our conference, which will be coming back in 2021 as we exit this COVID era, we hope. We have the Brotherhood of Caring, which is our support system or support group for the male caregivers of our gynecologic cancer patients. We have our Woman to Woman program, which is our peer mentorship program for newly diagnosed women. And we also do a retreat each year in the summertime. We're not able to do it this year, unfortunately, but we will be bringing that back in 2021. We do a retreat each summer for women who have recurrent malignancy to sort of bring them and their partners, be it a spouse or a caregiver, to talk about what's going on and help them through the process of recurrent cancer treatment. And the last thing I want to end with, we did this yesterday. We kicked off GYN Cancer Awareness Month. It's September, it's GYN Cancer Awareness Month, and we started with a celebration. And we learned something important about Facebook, which is that the audio on Facebook Live when you're wearing a mask is not very good. And so it left something to be desired. And so I want to end tonight on a celebratory note and an emphasis note. And I want to bring us back to where we have come from, because our program has certainly grown. It started with a small number of women who met and had an idea. It started with the vision of Susan and her heart and soul, which she poured into developing this program and establishing it and making sure it had a good foundation. But there are many people who continue to support our program and make it happen. And each year we raise one of these women up with our Survivor Impact and Advocacy Award. And so this year in 2020, we've recognized Razi Brilliant. And we did this yesterday on Facebook Live, and I don't think the words got conveyed. So to just make sure everybody knows, we raise this award every year to someone. We raise it in memory of Susan. We raise it in honor of all the women who are advocates. And we chose Razi because she really embodies what it means to be an advocate. She wears her teal nails. She uses every opportunity to tell her story and to make sure that women know that knowledge is power, knowing your family history is power. In her case, that's her story, and that's her emphasis. But each person who has had a gynecologic cancer has their story and their emphasis. And so she shares her story to help others. We hope everybody will find and share their story to help others also. And so I just wanted to say thank you again to Razi. We are grateful that you are a part of our community, and we are grateful for all that you do. And we are grateful for the ways in which you continue to honor Susan's legacy, and our program does so as well. So thank you very, very much, everybody, for joining us. We hope you got a sense of all of us, both in a clinical sense and in a personhood sense. We hope you took away some important messages, and we hope that we will see you every Wednesday for the rest of the month, or in the recordings that will be available, that you'll have a chance to view them. We'll be covering some other important topics. Dr. Beavis mentioned intimacy. Sexuality and intimacy will be one of our topics. We're going to talk about clinical trials. We're going to delve more into some of the details of clinical trials. We're going to talk about some of the prevention strategies that are available now that both Dr. Stone and Dr. Beavis mentioned. And so we'll be circling around to a lot of these topics. So hopefully we will see everybody again.